Now, I would like to briefly introduce our speaker, Dr. David Ansell. Dr. Ansell is the Senior Vice President and Associate Provost for Community Health Equity at Rush University Medical Center in Chicago. Dr. Ansell, you may now have the floor.
Thank you, and I'm honored to be here. And as I start, you can see on your screen a map of Chicago, or a diagram of Chicago. This was drawn from the point of view of community residents. Oftentimes you'll see Chicago or New York as big buildings, and then very little of the neighborhoods. But from the point of view of the residents of Chicago and the west side of Chicago, that I'm going to talk a little bit about in this talk, this is what they drew: beautiful, green, verdant, with lots of assets in the neighborhoods of hope and opportunity, not hopelessness and disadvantage. So I'm going to try to talk about the moment we're in, COVID-19 and Black Lives Matter. I'm going to say make health equity a priority. This is personally, but wherever you land. And then I'm going to talk about work we've done in Chicago to bring this all together. And I'm going to give you a little bit along the way of my own personal passageway here. As doctors, future doctors, nurses, it's critically important that we decide about our own practices. And sometimes it's going to have us pushing the boundaries of what's normed right now in our societies. And I call that the practice of social medicine or social nursing. So I have no disclosures. I don't get money from anyone for giving these talks, but I'm very honored to be back at Upstate where I started. In fact, I've been in Chicago since I left Upstate Medical Center. That's me in front of the old Cook County Hospital where I went to do my residency. And along the way, I've written a couple of books, County, Life, Death, and Politics at Chicago's Public Hospital. It's a memoir of actually learning how to practice social medicine at a big public hospital in Chicago. And then the book, The Death Gap, How Inequality Kills, my observations that I'm going to talk to you about today. But a little bit about me. I grew up, my parents were immigrants. That's my mother. She died a couple years ago. My older brother and me, baseball was not my fortitude. I was not so good at it, but I was smart enough to get myself all the way to Upstate Medical Center because I wanted to be a doctor. But my family history was kind of dark. My mother and father's family were on mainland Europe, and they were all annihilated by the Nazis, victims of racism, mass incarceration, and genocide. This is a picture of my great-grandfather, my mother's grandfather. In 1938, my grandfather and uncle went to Poland to ask him to leave because they saw the war was coming. And he said, no, I have to tend my flock. This came from a files of a Nazi soldier who posed him in front of Jewish tombstones, and he was murdered a year after this. So this was in my background, and I grew up during the civil rights movement in Jim Crow and seeing awful racist policies. It turns out that the Nazis picked up their policies on scientific racism from the United States. They came here, studied what happened to blacks in the South. So this is my family background, but I decided that I was going to be a doctor, but I couldn't help but seeing the parallels between what happened to my family in Nazi Germany and what was going on in the United States. But in the United States, I was assigned to be white. An assignment I didn't completely understand till I got much older. And that assignment allowed me to achieve things here that I wouldn't have been able to achieve necessarily in Europe. I went to Upstate. This is us up on Westcott Street. You can see me in the middle here with the long ears and the droopy nose. But all of us in this picture, this is my wife. She went to medical school in Chicago, but we were all upstate grads, and we were very disheartened about medical school and the lack of connection between what we were learning in medical school in society. In fact, I was so disheartened that first year of medical school that I decided I was going to quit and go to the Syracuse Forestry School and be a forest ranger because I like the outdoors. I'm an old tree hugger. But the group of us and many others got together and we began to study the US healthcare system. And at that point in time, I knew what I wanted to be, and we all knew what we wanted to be. We wanted to be doctors, but I wasn't so clear on why I wanted to be it. And what became clear to us as we studied the US healthcare system, this is now back in 1974 and 1975, was that healthcare is a human right. And when I describe myself now, I describe myself, I'm a doctor, I'm a social epidemiologist, I've been a chair of a department of medicine, I'm a program director, I've leading health equity efforts at Rush. But much more important than the what is the why. And the why for me is that health is a human right. And so I consider myself a human rights activist that motivates and drives me. And I've been able to apply some principles of social medicine that require us oftentimes to break through the boundaries that are put in front of us on behalf of our patients and community. We grow up as good boys and girls. What gets us to medical school oftentimes is that we were rule followers. When I said, take your pencils out, you took them out, put them back. But actually to practice social medicine requires us to actually break the rules. We take an oath to a higher order. When we take a public oath in medicine, it's one of the few public oaths you'll ever take in your life. And that oath is more important than the rules within organizations. I'm not saying you don't follow the rules, but there are sometimes if you're going to practice social medicine, you have to break the rules. So when we got done with residency, we all matched one place on our match list, and it was Cook County Hospital because we all wanted to go to the same place together. And we went to Cook County Hospital. It had been disaccredited 2 years before we got there. There was the longest doctor strike in US history. These are the doctors defying a back to work order. They went out for issues of patient care, soap for the patients, toothbrushes, EKGs, Spanish interpreters. And this man in the middle, Dr. Jack Raba, is still a friend. He's old guy like me. At the end of the strike, he was thrown in Cook County Jail for 10 days for defying a back to work order. But they won the strike. And this is the place where I decided I would go train because it was the intersection of everything that was right and wrong about healthcare in America. On the one hand, an institution that took anybody, regardless of ability to pay, but on the other hand, often lacked the resources to take care of those patients. But I'm going to bring you to now. So that was then, and this is now, and that's going to be a little bit of the theme of this talk, is going back and forth. So, you guys are going to medical school in the moment of a pandemic that's a once a century pandemic, but it's layered on top of another pandemic. In many ways, and these are just two pictures. The virus is killing our people in the Black Lives Matter movement. So this was supposed to be the great equalizer, right? A virus for which no human beings are immune. And so we're equally susceptible, but you got to see in front of your own eyes how inequality actually kills, given the same circumstances. Because what the virus did was plant its seeds and roots into the social fault lines that define American world society. And as it planted its seeds, people who have been historically marginalized, oppressed. These are words that the words matter, how we discuss it. These are into the lives of people who've been historically oppressed, oftentimes for generations, and the virus needs took advantage of those social conditions and then decided who lived and who died. And that was many times these things are invisible to us because we take the social fault line for granted as being normal. So that we're in the midst of a trifecta, but I have to tell you, we've been in the midst of a trifecta we've always been in, but it's been often invisible, just like the invisible Native Americans on whose lands we live. So one is the trifecta of the virus itself, like a century pandemic. But then there is racism and its long reach and its condition as an underpinning of poor health. And then third is the economic dislocation that's occurring as a result. So not only do we have the virus, but we all witness on screen the lynching of George Floyd, not the first one, by the way, one of many, but the one that we all got to witness together, where he is narrating his own murder in front of our eyes. And, you know, people who had never paid attention were shocked by this, but this is not, should not be new or surprising to anyone. But it did shock and launch what we hope will be a successful Black Lives Matter movement, well, which is more than just ending racism and white supremacism in police actions, though that's part of it, but across our institutions. So our work as doctors, as nurses, as health professionals, as administrators, is how do we change a narrative? And how do we think about leveraging our voices to change narrative? So I'm going to take you back a little bit. So this is just one of many depictions. This is from World War II. It's a poster about the blood supply, because like many things in the United States, we segregated blood. And so if you were a Black person, you could only get Black blood. And if you're a white person, you could only get white blood. And then during World War II, they decided because white GIs were dying and they needed blood, they finally decided to merge the blood supply. And science too has proven in chemical and physical and microscopic tests that white and Negro blood is identical. And I point this out to you is that all of American medicine is built on a foundation of white supremacism. And it took me many years as a white man, as a white physician, as a white physician leader to say it and name it. And the vestiges of white supremacism still persist in medicine today. And it's up to us to change that narrative. And when we get to COVID, when you think about trusting science, and that's probably the wrong message to give to Black and brown communities. Trust the science. Because if you trust the science, Tuskegee was a scientific experiment. This was science. But it was eugenics, was the science that was created to perpetuate the myth of inferiority based on skin color. Still persists to this day. So it's up to us to change the narrative. So that was then. This is the early 2000s. I just point these two, books out. There are many, many books. But on the left is Unequal Treatment, a report by the National Academy of Medicine that looked at treatment for Black and white people in the United States and showed that for about every condition, of course, you know this, that Black people got worse treatment or inadequate treatment compared to white people. That persists today. And it persists in many ways today. But unequal treatment, that was about 20 years ago. And here's another one. In 1990, the United States government decided that if we're going to improve life expectancy in this country, we would have to address the low life expectancy among Black and brown people, the lowest groups in the United States. And so they made the goal in 1990, by the year 2000, in what was called the Healthy People 2000 report, was to reduce health disparities. And in this report, published in 2000, Healthy People 2010, the goal was by 2010 to eliminate health disparities. Government policy and how well have we done? We've actually gone in the wrong direction. So just to point out that it's up to us, it's our work to do, but it's critically important as we do this to name the root causes. So, and you know, I just say this is that, you know, we've had an imbalance in the way that medicine is taught, in the way that scientific racism persists in healthcare. Every one of us who goes through medicine is tainted by the legacy of scientific racism and by its current forms in medical school. We eliminated EGFR at Rush. So we got rid of it, including education for patients and doctors on this racist basis. But we get labs from LabCorp and Quest, big national private labs. And when they come into our medical record, they perpetuate the race-based EGFR. So now we've done enough to eliminate it at one institution if we don't wipe it out everywhere. And so, you know, the scales right now are balanced really against equity. And it's up to us again to rebalance the scales. So, you know, as a doctor in medical school, we learn a lot about beliefs, behaviors, and biology. I call them the 3 Bs. You know, those are how we learn medical school. How do we change people's beliefs about COVID vaccine, right? You name anything around diet, around how do we change health behaviors or precision medicine? How do we target treatments to people's biology? But here's a story I tell in groups like this. A 16-year-old Black teenager who lives on the west side of Chicago has a little bit more than a 50-50 chance of living to the age of 65. And I want you in the audience now just to think about causes of death. And in your mind, conjure up, why would a 16-year-old Black teenager on the west side of Chicago, that neighborhood I showed you before, only have a 50% chance of living to the age of 65? A lot of people say violence and gun violence because you think of urban areas and teenagers and death and premature mortality, you think of gun violence. But actually, over 50% of the premature mortality, not just in Chicago, but around the country, are from cardiometabolic disease and cancer. In fact, the top five causes of premature mortality, meaning death before the age of 65, are heart disease, cancer, infant mortality, homicide, and the opioid overdoses. So five causes of death. So oftentimes we go to violence, and yes, it is a form of violence, but I call it structural violence. And it's structural because it's designed into our policies, our laws, our policies, our procedures, our norms, and our structures, the way our society and institutions work on a day-to-day basis. And it's violent because people are harmed or killed early as a result. And structural racism is a form of structural violence. So I went to our board. Here I was, a little bit my work history. I went to Cook County in the 1970s. I stayed on as a resident, after residency. I became a chief resident, became an attending position. I became the head of general internal medicine. I moved to another hospital in Chicago where I was a chair of medicine, and I got recruited to Rush to be the inaugural chief medical officer. You couldn't be higher up. But I realized, and Rush is ranked #1 in quality in the country in a US News and World Report hospital. But something was wrong. And this is what I took to our board. And this is true in any city in the United States, in fact, across the world. But this is Chicago. So if you live in the Loop in Chicago, you can live to be 85 years old. And if that were a country, it'd be ranked first in the world. But if you go down the blue line, Rush is located right in the middle here, right at this intersection of the blue and pink. 3 stops past Rush in West Garfield Park, a neighborhood that is concentrated poverty, and it's a Black neighborhood. The Loop is a neighborhood of white concentrated affluence. Life expectancy plummets to under 69. And if this you ask yourself, when was the last time in the United States that life expectancy was under 69? You would have to go back to the 1950s. So 7 stops down the blue line, 3 stops past our hospital, and life expectancy was under 69. And I asked our board, I said, if we're going to improve health, we have to address the conditions under which people live, work, and play. And we're going to have to address how power, money, and resources are distributed. Here we were. When I came to Rush, the goal was to be the best in quality. And we became the best in quality. But now we changed our mission to improve health. And if we had to improve health, we had to suddenly address the social conditions under which people live. Now, you heard the word social determinants of health. I look at them, there's social needs that individual patients have. I have hunger, I don't have housing, I have transportation needs. Those are social needs. But then there's social conditions, and there are political determinants of health, there are economic determinants of health, and there are other structural determinants of health. And in our community health needs assessment, which this map became part of, we named for the first time in the history of our institution that racism, structural racism, and economic deprivations, acts of oppression, were responsible for the life expectancy gap. Now, young doctors and nurses, consider for a minute this fact, that if everybody in the United States took a statin to lower LDL cholesterol, it's a beautiful drug, it's almost precision medicine, it blocks the LDL receptor. You can't have a better drug, for a problem. But if everyone in America took one as a part of preventive cardiology, you would add 20 minutes onto the life expectancy of Americans. So, but imagine what you could do if you could change the conditions between the Loop, 85, and Garfield Park. You could add 16 years onto the life expectancy. So as doctors, you have to ask yourself, where should you be spending your time? This is critically important, and why I gave up being chief medical officer, and I'm a chief equity officer now, leading efforts with lots of other people to address it and convincing our health system that this is the necessary work of our times. This is the practice of social medicine. And this is not just about Chicago. So this is from a very famous economist called Raj Chetty. You might look at some of his YouTubes because he has a lot of insight in so what does income inequality and wealth inequality have to do with life expectancy? So what this tells you is if you're in the top 5% of the income in the United States, it doesn't matter where you live. you're going to have a long lifespan. So the rich live no matter where they live. But look down, if you go down towards below median income, there begins to be a split in life expectancy that seems to be place dependent. And so if you live in New York City, if you're poor, you're going to live about 15 years longer than if you live in Birmingham and you're poor. So where you live dictates when you die. And this is how public policy makes a difference. So again, think about where you're going to spend your time when you're done. You can be terrific doctors, but we have an obligation to address the political, the economic, and the structural determinants of health through our agency as being assigned privilege. I just want to tell a little bit more about how I convinced our organization to do this. So I showed you the life expectancy. These are our patients and their cost of care along the same L tracks, essentially. And if you lived in the lowest life expectancy neighborhood and had diabetes and hypertension, you cost 2 to 3 times as much than if you lived in a concentrated neighborhood of white affluence. Oftentimes we focus on black concentrated poverty without focusing our attention on how that happened. And it's because capital was removed from these neighborhoods and put into neighborhoods of white concentrated affluence. Again, these are acts of affliction, they're acts of oppression. We have to name them, and we have to name them clearly. Now, pause, because when I was where you were at, I knew something was wrong. I knew from my family history that racism and white supremacism could kill, and that genocide was a real deal. But because I was assigned to whiteness, it took me a long time as a white man, even one who came to Chicago, worked with poor black and brown people. It took me a long time to name white supremacism and racism as root causes of poor health. And I had to do a root cause analysis on myself and ask myself why 5 times. So here's a really good thing to learn. If there's an event, something goes wrong in a hospital, or even in your life, if you ask why 5 times, you will come to the root cause. Critically important that you name root causes, because if you don't find, there's not often one root cause, there can be many root causes, but if you don't name them correctly, you're not going to prevent the next patient from experiencing harm. So I did a root cause analysis on myself, and I asked myself why 5 times did it take me so long to name white supremacism and racism as a root cause of poor health outcomes in the United States. Well, why? Well, I didn't feel comfortable, using the words in the language. Uh, well, why not? Why didn't I feel comfortable using the words in the language? Oh, thank you. My grandson is giving me a muffin. So why didn't I feel? So why didn't I feel comfortable? Well, I didn't have practice using the words. Why didn't I have practice? Well, I wasn't around people who use those words commonly. Well, why wasn't I around people who used those words commonly? Well, they were a nice group of people, and I wouldn't want to say anything that disturbed them. Well, why wouldn't I want to say anything to disturb them? Well, they invited me into the room. And so what I realized was I was in white spaces. And in white spaces, it wasn't polite or even normed to speak about racism and white supremacism. And so uh, I thought back to my great grandfather in Poland, and I thought about the obligation to speak. And it wasn't up for the Jews in Poland or Germany to speak on their behalf. It was up to the Poles and the Germans. Just like in the Me Too movement, it's not up for the women to speak on women's behalf, it's up to men. And in this situation, it's the responsibility of every white person in this audience to get comfortable speaking about how white supremacism and racism kills, and not rely on your Black colleagues to be the ones to do it. It's our responsibility. We are the ones who are benefiting from the privilege. And that benefit comes in day-to-day opportunities, that doors open for us that are closed on other people. It's this is how we leverage our privilege. But that was my personal story. We found that our employees who lived in these low life expectancy neighborhoods had a high degree of financial distress. And so now this is how the iceberg here, how health inequities rise. At the top are differences in quality of outcomes. As you move down this iceberg, it's differences in access to care. But at the bottom, it's the life opportunities that people are exposed to through social conditions that make a difference. So this is how racism, sexism, able-bodyism, I'm going to share these slides with you so you all have them. Able-bodiedism and other things make a difference. So, and I'm going to show you some more data on, but here's a lens you can all put on a policy, a procedure, a moment in time. How does this moment, how does this policy, how does this, what this person just said, perpetuate historic injustices that have white on top, Black and brown on the bottom, men on top, women on the bottom, or queer on the bottom, wealthy on the top or poor on the bottom. You put an equity lens on every time a decision is made or a system is made, and ask the question, who is not in the room right now? Who's not here who would be important around this decision, who might be marginalized or disadvantaged by the system? Because racism and other forms of oppression don't necessarily have an identified perpetrator. These are self-perpetuating systems that perpetuate whiteness and privilege on top. So here's from Nancy Krieger. I'm just going to now, I went from ideas to a model to think about this just for a second. This is from Nancy Krieger from the Boston School of Public Health, one of the great thinkers of this, eco-social theory. So how does racism get embodied? So one of the things that got me to the space, I noticed in my patients a degree of disease that was resistance to medication that I couldn't understand. And I began to understand that there was something about where they lived and what happened to them that made a difference. And so, and this is where we got off into the biological road race versus the social road race. But in the upper left-hand corner here, you see the embodiment. So privilege gets embodied in my chance of long life expectancy. But racism gets embodied in many ways. It gets embodied in doctors and the way Black patients and brown patients, even women, are treated. But it gets embodied in the person of our patients in many ways through biological mechanisms that racism stimulates through neural pathways that affect the inflammatory systems, the nervous system, and what. And there's an interplay of exposure, susceptibility, and resistance, accountability, and agency. We know there's something called biological weathering, where the telomeres at the end of chromosomes are shortened in people who are exposed to social stresses. We know there's vertical transmission of the effects of racism on babies. So we know these things occur. We don't understand enough about them yet. There's a clear relationship of cause and effect from social phenomenon to biological phenomenon. And we've known this around the world, that the social pecking order, no matter what it is, has about a 15-year life expectancy gap from the top to the bottom. And then you see the political economy and political ecology. This is how racism is embodied into laws, how your health systems are organized, And then you get class injustice, racial health injustice, gender and sexuality injustice. It's not just racism, but it's racism first. The lens of racism helps us understand other forms of oppression. Then you get population distribution of health. And of course, at the bottom, there's the life course. And then there's these very levels of global, national, regional, area, household, individual, right? There's many ways it plays out. Anyway, everything I told you has a theoretic model that explains it. So it's important for us to understand all the ways that racism kills. So number one, we have to name it. But in life, you get 1 point for naming the problem and 100 points for fixing it. So just because we've had, a fantastic resurgence of Black Lives Matter movement doesn't mean we're even close to solving the problem. So how does structural racism kill prematurely? Concentration of Black disadvantage. And what I told you before, we've got to focus on actually concentrated white affluence or affluence of people who've been assigned white, like me. It's a zip code effect. And when you do that across generations, it has generational implications for who lives and dies. Structural racism, police incarceration, schools, hospitals, and the like. The embodiment of racism, that has many embodiments. That's why I say when you tell someone who wants to get the vaccine, trust science. Well, mistrust of the health system was probably a safer, a safe bet for many people if you were Black. And then the embodiment of privilege. There's bias, implicit and explicit bias. I don't make a difference between those. Microaggressions, macroaggressions, they're all acts of violence, right? It may be micro to you, but when you're receiving it, it's not micro at all. Inequality and quality of healthcare delivery, and then inequity in healthcare outcomes. So here's something, think about for a second. We have a capitalist system. Capitalist system do fantastic things some ways, iPhones, everything, goods, right? But they do it at a cost of oppression. And capitalism does one thing well, it concentrates capital into the hands of the few. That's what it's designed to do. Well, we have a capitalist and racialized health system. Why do I say that? Is because we don't have single payer universal health care where everybody gets the same card. And so because of white privilege and white concentrated economic advantage built into our country's basic premises, perpetuated now for 500 years, from colonialism to capitalism, we've applied that same system to our healthcare system. So wealthy healthcare systems that take care of better off people do better, and healthcare systems that are in Black and brown neighborhood are undercapitalized. Many of the systems have to close, worse services. One of the things I observed being a doctor in Chicago, I worked along one street. It was an old Native American trail. People don't remember it anymore. I call it one street, two worlds. I'm the exact same doctor. My patients were the same patients. And yet the health systems along that street, depending if they served all Black populations or like Rush, a wealthy academic medical system, and actually serves a pretty broad population. Where you got your care dictated how good your care was. And there was no better way to see this than during COVID. If you ended up in a neighborhood, in a black neighborhood, it wasn't the doctors, the nurses, it was the ability to have the kind of equipment, the kind of staffing you needed to save lives. And people died disproportionately because of racialized capitalism in healthcare.
4 minutes until questions.
All right. I'm just going to pass over this. These need to be system strategies endorsed by your leaders. You got to name racism as a root cause. You got to build wealth among low-wage employees. You've got to hire, buy, hire, invest locally. There's ways for healthcare institutions to do this work. I'm not going to linger on it. We created a racial health equity collaborative in Chicago. 6 hospitals partner with the community to holistically address the social and structural terms of health, including structural racism. It partners power and decision making with community leaders, and the aim is to reduce that 16-year life expectancy gap by 50%. So this sort of racial health collaborative is a way that this work can be done. We've got to leverage all the tools we have to reduce these inequities. We're focusing on health and healthcare, economic vitality, education, and neighborhood investment, and addressing these 5 drivers of life expectancy. But what happened, I'm just going to end on this note, and it's about COVID. When the first 100 deaths of COVID were in Black people in Chicago, the mayor said, it's outrageous, it's unacceptable, and it takes your breath away. Asked her team, what do we do? And they came up with some ideas. She said, that's not good enough. Call West Side United, our racial health equity collaborative that we had set up 2 years ago based on power sharing to reduce racial health equities. And we put together a racial equity rapid response team at the city level. We were meeting twice a week and bringing resources into the neighborhood, not just healthcare resources, they were bringing them to food, money, and other things. And Chicago has done a pretty good job, not a perfect job, but a pretty good job at managing the racial inequities in COVID response. But when George Floyd was murdered, we got the providers around the group to put out a common statement. It says it's undeniable racism is a public health crisis. And not only stating it, but what are we going to do in response? You can see on the left, Rush's billboard, Black Lives Matter, was without controversy on our board to put this up there. Black Lives Matter, period. Statement of fact. But now we're working on a national scorecard, just like white coats for Black Lives have, that every healthcare organization has to measure itself up against to eliminate racism within our health systems. This is a famous basketball championship duo from the 1960s, Bob Cousy and Bill Russell. Last year in the New York Times, Bill Russell had all kinds of racist attacks on him during his career, including human excrement left on his bed, epithets at every stadium he went to. And Bob Cousy and he were interviewed last year, and Bob Cousy reflected on the racial injustices he faced as captain of the team. And he said, I wish I had done more. None of us should look back on our lives and say we wish we'd done more. And so I'm going to take questions here. This was designed by our communities. Say, what would happen if we all work together to eliminate the impact of structural racism and economic deprivation on our communities? I'll just end on this Chicago Tribune headline, changing the West Side story from violence to victory. So I became a doctor at Upstate Medical Center and learned that health is a human right. And if you all join in this work, we can make a big difference in our world. So thank you.
Thank you so much, Dr. Ansell, for that incredible presentation. Now we're going to transition to questions. Our chat monitor, Alana, will be taking questions.
Hi, thank you everyone for the questions. This first one comes from Gargi Mishra. She wants to know, how do you have a respectful conversation with someone, especially another person of color, who denies even the existence of structural systemic racism? It's a peculiar situation of the internalized oppression, and I would love ideas on how I could constructively have a conversation with these types of people.
Yeah, you know, a lot of this, well, thank you for that question. You know, first of all, in the end, I'm not that interested in changing what people believe. I'm much more interested in actions, because actions speak louder than words. I do think an approach to life is to come from curiosity. First understand and seek to be understood. But on the other hand, I'm a GSD kind of person. Get stuff done. I don't say it in that way, but you know, there's an urgency. So one of the things about inequities is that there's an urgency to this work because they're unjust. They're not just differences, they're unjust differences. You know, our job is not to convince people. You need nothing more than to see what was it last week? On the one hand, on Wednesday morning, we wake up and a black man and a Jew were elected to Georgia to be senators. And by midday, white supremacists had invaded the Capitol, right? Different ideas exist in the world. Our work is to advance our ideas and advance justice. And it's not worth spending the time trying to convince others. Having the conversation, yes, but you know, our work is to get things done.
Thank you. So just a reminder, if anyone wants to ask a question verbally, you may raise your hand using the participant tab. Otherwise, I'm going to keep reading some questions from the chat. We have a question from Simone Seward. She'd like to, she says, thank you for naming the root causes of inequalities. She'd like to know how we can train current and future healthcare providers to operate, navigate within the system. Oh, I'm sorry, as more chats come in, it scrolls away from me.
Yeah, but the issue of, so we at Rush, you know, I've always done this. So this is an inside outside strategy. And you know, even the word equity sometimes is not specific enough. You know, I say anti-racism is an inside outside strategy that includes the other forms of oppression as well. And the inside part's critically important because our institutions have been built on a foundation of white supremacism, and our educational systems oftentimes have as well. And it's difficult to say that. I know there are educators in the room because it's hard for you to see that. So how we even recruit into medical school is important, you know, in our selection process. But I actually think we have specialists like cardiology and neurosurgery, right? But we don't really have specialty in social medicine. We need to be teaching these ideas and constructs, which are hundreds of years old. W.E.B. Du Bois in 1899 published a book called The Philadelphia Negro, in which he showed that the social conditions under which Black people lived caused poor health outcomes. Are we teaching W.E.B. Du Bois in medical school? Are we teaching Harriet Washington in medical school? And so you think it's like that. There's a whole literature. The problem is most of our instructors are white or assigned white, and they do not have the self-understanding of how they carry their own privilege. And so there needs to be a revolution. I'm almost done. My grandson wants to go to the toy store. But so the point is, we need a faculty that's very, very different. You cannot teach racism unless you understand it. We've tried to teach it in our medical school and realized our instructors had no idea of how to do this. So there's got to be a complete revamping. And then we need standardized patients before you go into the clinical years, where you are, rather than just take anti-bias training, which is good, but it's not going to do that. We have to see how you manage a clinical encounter before you're allowed to go on the wards that deal with racial mistrust, that deal with language barriers, immigration stuff. You need to have competency before you hit the ward. So we're trying to do some of this stuff at our medical school, but we should all be working on this.
Thank you so much, Dr. Ansell. So at this time, I have to unfortunately end this presentation so we can keep the conversation going and move on to our next sessions. But I would like to thank you again, Dr. Ansell, as well as our sign interpreters for this amazing session. And I will end it now so Dr. Ansell's grandson can go to the Toy Star.
All right. Thank you, everyone. Good luck in your careers. Never give up. Never give up. All right. Bye, everyone.